Hi, everybody. Good afternoon and welcome to this very interesting discussion that we're going to have. As we know, it's International Women's Day tomorrow, and on behalf of KHPT, let me welcome you all to Addressing Gender and Stigma Barriers to TB Elimination. KHPT is an organization that has been founded with a mission to enhance health and well-being of vulnerable communities. And I'm really pleased to welcome our wonderful panel. I'm going to take a minute to introduce everybody and we'll get on with our discussion. Just very happy to welcome Ms. Sangeeta Patel, who is the Director of the Health Office at USaid India. She has been vocal about the need for involving women and members of the transgender community, very important as a part of TB elimination efforts across the world. She highlights the importance of looking at stigma and social factors to ramp up the fight against tuberculosis. Very proud to welcome Dr. Dalbir Singh, who is the president of the Global Coalition Against TB. Dr. Singh has served as the National Secretary of the Indian National Congress. He also had a brief distinguished career in the army, where he participated in counterinsurgency operations. Dr. Singh also serves as the advisor to the board of Girl Rising India, a civil society organization for the empowerment of underprivileged girls supported by USaid. Dr. Rajendra Joshi, welcome to the conversation. He is the Deputy Director General of the National Tuberculosis Elimination Program. Dr. Joshi has been actively speaking about the important role that corporates can play in addressing delay in diagnosis, stigma, and incorrect treatment in TB. He pursued MBBS from the University of Mysore. Welcome, sir. Ms. Amy Piatek is the Senior TB Technical Advisor at USaid. She holds an extensive experience working with the WHO, New York City Department of Health and Mental Hygiene. Of many things, she has written about the cost-effective implementation of new point-of-care diagnostics for HIV and TB, need for placing testing methods in the context of a comprehensive and functional TB diagnostic networks. Dr. Dr Ditty is the Executive Director of Stop TB Partnership, Geneva. Dr. Ditty is a physician and public health expert and has been instrumental in ensuring a strong voice for the TB community, especially the most vulnerable and marginalized. Ms. Blessina Kumar, welcome. She is the CEO of the Global Coalition of TB Advocates. A public health activist, she holds extensive experience working with marginalized populations and internally displaced populations in Sudan, running a successful community health promoters training program, which was recognized by the government of Sudan. She endeavors to bridge the patient-practitioner divide through patient literacy at community level and policy advocacy at macro level. Dr. K.S. Sachdeva is the Regional Director, the Union Southeast Asia at International Union Against Tuberculosis and Lung Disease. Previously, the Additional Deputy Director General of the Central TB Division, he has been very important in terms of capacity building and rational use of drugs, procurement, and logistics management. Dr. Rehana Begum is the Project Director, Breaking the Barriers at KHPT. Prior to this, she has worked with the World Health Organization, UNICEF India, Kiribati, Fiji UNICEF, Lao PDR, UNICEF, University of Toronto. Welcome, Dr. Rehana. I just want to start the webinar by informing everybody that we are recording the webinar. And if you have any questions, please do drop it in the question box and I will be taking that towards the end of the conversation. I am Dr. Supriti Chauhan, leading advocacy for Breaking the Barriers, and welcome again. To start the webinar, I would turn to Ms. Sangeeta Patel for her opening remarks. Ma'am, over to you.
Thank you so much. Let me just start, first of all, with a warm welcome to everyone and really just appreciate, especially in this forum, the incredible advocacy and momentum and energy really in this room. I think that there's no better way to really walk up to or come running towards International Women's Day than to really honor and respect, especially the differential roles of gender on even this subject, but even especially the areas of stigma and how to overcome them. On behalf of the U.S. Agency for International Development, let me first start by just thanking our implementing partner, KHPT, and the Global Coalition of TB Activists, GCTA, as well as the Central TB Division, and of course the Ministry of Health and Family Welfare of the Government of India. Today we're joined by esteemed panel members to really look at what we can do, especially to not only talk about the challenges of tuberculosis and how it affects populations differently, but what we can do as a matter of fact as a community in this area. In the case of TB, despite the COVID pandemic, what we know is that it remains one of the world's most pressing health challenges. And there's adequate evidence to really indicate that gender contributes significantly to the epidemiology, the risk factors, the probability of diagnosis, access to care, on down to treatment adherence, and even overall impact of the disease in communities. So from our perspective, certainly at USaid and even beyond, we know men as well are also more susceptible to having tuberculosis, but the impact of the disease and access to care is really greatly seen, especially by women, and especially those from LGBTQIA plus communities. They face higher rejection, lack of financial independence, and of course, they're oftentimes beaten, stigmatized, live in fear or retribution, live in discrimination, and really have to significantly have a different means of support to ultimately eliminate this disease and make them at a level equitable for everyone. We have to be able to account for these social factors and in fact note that especially for women, TB progresses more quickly, especially in women of reproductive age, than in men of the same age group. So TB places pregnant women and their babies at risk, and certainly pregnant women with HIV and active TB. So from our perspectives, when we face any situation where you increase the risk of maternal mortality, it definitely means there's high stakes at play here, and we've got to do more. TB, undernutrition, and even the role of caretakers, as well as even women's roles when it comes to, cooking in the family, using solid fuels, all of these essentially place differential risk and for women in particular. Men also are at risk, of course, due to their employment in areas such as mining, quarrying, metal, and construction industries. So really what we see here is a phenomenon where we see many people ultimately impacted. Fear of loss of income and consequences, especially due to absence from work, is out there. And definitely men oftentimes, are hindered from seeking care, while women, of course, face access, difficulties, especially due to stigma, and also the need to prioritize household chores over health, lack of money, self-care, or even financial dependence. So it's a multiplicity of these factors, of course, all layered with COVID-19, which really create an equation, an explosion, if you will, when it comes to the current situation, especially for female patients, and especially those ways in which it presents challenges for us in terms of ways in which we can provide support to influence their care-seeking behaviors. Whether it is stigma, whether it is care seeking, women oftentimes just simply do not want to disclose their status either within or outside the families. And certainly women worry about the negative impacts that a TB diagnosis can have on their families, on their children, and ultimately really due to ostracism even within the neighborhood or even communities. I think it's within this light that we see, of course, the pandemic as exacerbating the challenges that were already there. The underlying foundation really where TB especially was already there and presenting a pressing concern. So once the pandemic began, critical health resources were diverted, and oftentimes you would see a healthcare system that was already stretched even further. And of course, the impact is seen even now, not only within India, but even globally when it comes to being able to really understand and treat TB. From our perspective at USaid, I'm proud to say that we have partners, and of course, across this virtual space, even we've really looked at gender and how we can take it into consideration, especially for our program designs, and even to really improve the lives of citizens around the world. So for at least for USaid here in India, we're really trying to promote gender equality and social inclusion, and especially trying to do whatever we can to support vulnerable populations, whether it's ensuring that projects don't exacerbate or perpetuate gender and other social disparities, or reduce disparities where possible, or even empower women, girls, and members of traditionally disadvantaged groups. So I think from our end that our projects regularly undergo this type of GESI analysis and compliance, and we're certainly going to be able to continue to improve and scale, we hope, comprehensive TB services while building on decades really of support to over 15 million impacted by this disease. We've made a lot of progress. There's a long way to go. I know there's a lot ahead of us, especially in this forum. And so I'm looking forward to not only celebrating with each and every one of you and looking for ways to ensure more equitable access to health and of course to TB services, but also trying to figure out newer ways that we can continue to reach out with you and partner in this area to promote equity, inclusion. Thank you so much.
Thank you so much, Ms. Patel. And with the hope of, there's a long way to go, but I think small steps matter. I'm going to start us off today by actually, before we get into the conversation, I just want to welcome all the audience. I know everybody's here from across the globe, welcoming everybody. And if there are any questions, again, please leave it in the question box. But just wanted to also start us off by a poll question. And this is because I want us to engage with the audience. It's going to come up on the screen. I'm going to request the team to place it so that everybody can take a chance at answering that. You can vote on this and, we'll just see it live as you do this. Addressing gender and stigma barriers to TB elimination. What is the most common experience of women with TB? Marital problems, divorce, separation, delay in seeking treatment and non-compliance, forced to hide symptoms from family and others, do not get adequate nutritional support. Just going to give it 10-15 seconds and I'll ask the team to please put the results up. Post that, we hope to get into the conversation where I'll be talking to the panel and welcoming the audience again. I think we are moving towards, I can see about 45% delay in seeking treatment and non-compliance, for which there are multiple reasons, and I think we are going to hear them. We are also going to hear experiences. We are going to have some interesting questions come in. I'll request the team to stop the poll. Can the team please share the results and then we can stop the poll and get into the panel, please? Okay, so as the team does that without delaying everybody, I know time is short. I want to start us off by talking to Dr. Singh. Dr. Singh, welcome again. And my question to you is that you have been at the forefront of policy advocacy for elimination of TB in the last 10 years, having successfully led to landmark initiatives by the Government of India. What should be our core strategy to combat TB, which affects women, keeping in view challenges like gender equity and stigma, sir?
Friends, we at the Global Coalition Against TB have been literally at the nucleus of advocacy in the last 10 years, with active support of more than 40 parliamentarians cutting across the party line, and also backing up nearly 24 distinguished experts from diverse fields of public health. And I can tell you, we have had the privilege of collaborating with the government, the civil society, the private sector, the local governments, and the communities. And our sustained advocacy has contributed to landmark initiatives of the government, including banning of serological tests, introduction of molecular diagnostics, integration of private sector, establishment of National TB Research Consortium, nutritional support, use of ICT, and also strengthening monitoring mechanism besides valuable inputs for national strategic plan. It has really been an honor to be a vital component of NTEP endeavor to end the epidemic by 2025, a deadline which is committed by our Prime Minister on the floor of Parliament as well as in the UN General Assembly. We are all aware that tuberculosis kills more people in history than any other infectious disease, and it continues to devastate us. It's a fact that more men are affected by TB because of biological mechanism, but women and transgender experience the disease very differently. Gender is a significant influencer of epidemiology, risk factors, treatment adherence, and access to healthcare. For women, TB care is constrained fundamentally by social, cultural, and financial barriers, which lead to under-notification. TB in women creates orphans and impoverished families. TB is responsible for more deaths among women of reproductive age than all causes of maternal mortality put together. There are a large number of unreported TB cases in the face of misery of abandonment, rejection, and violence. In 2020 alone, only 18 lakh of estimated 26 lakh cases were reported amongst women because of huge burden of stigma. Women are deeply impacted by fear, stigma, undernutrition, and delay in their diagnosis, neglect in their care, perpetuates poverty, adversely impacting our economic growth. 10% women with TB end up in divorce, 16 to 18% face isolation and societal issues, nearly 14% rejected by the husbands, while they are the principal givers to the families. TB among mothers increase the risk of prenatal death by sixfold. Women with HIV increase risk of have double risk of vertical transmission. Pregnant women with HIV increase risk of maternal infant mortality by nearly 300%. And also in high HIV burden settings, TB also accounts for another 15 to 34% cases of obstetric mortality. Gender equality and gender equity can be addressed by using various approaches, including bringing about legislation, organizational processes, promotion of awareness, and stepping up information gathering. Therefore, we obviously needed appropriate policy framework coupled with the resilient health system to overcome gender inequities. I'm glad that finally we have a framework for gender responsive approach based on the principles of human rights and also in resonance with 2018 resolution of United Nations, which promotes equity, ethics, and gender equality with an integrated approach and tuberculosis. The policymakers can facilitate implementation of these laws and also strengthen mechanisms to monitor progress as far as prevention, detection, and treatment of the disease is concerned. We also need to foster strategic partnerships and synergies across the health system, including TB, HIV, maternal, neonatal and child health program, and also primary healthcare services. There is also an urgent need to promote disaggregated data by sex and age. And also there is a need to develop focus on women-centric research and development and women-centric drugs. We must also integrate TB screening and investigation into entire reproductive health services. Challenges like discrimination, social ostracization at the workplace and within the community, and other vulnerabilities could be addressed by deeper engagement of communities, institutions of local governments, and paradigm shift in our societal attitudes. Elected representatives at all levels play a very, very vital role in this transformation. I'd like to briefly touch upon India has highly underutilized constitutionally mandated local governments, nearly 260,000 of them in the urban areas, in the rural areas, what we call the urban local bodies, and then we have panchayats at the district, block, and also the village level. So they have a very, very important role to play. And there are 260,000 of them, like I said, and there are 3.2 million people who are elected every 5 years through the constitutional process. And healthcare is a primary task. Let us use them. I've requested the government time and again, and I think no effort is being made to integrate them. We all know stigma is a major barrier to accessing TB care and leads to enormous suffering, even though disease is entirely curable and preventable. Young girls too get adversely affected by TB, and because of stigma tied to the disease, they are forced to not share their status, seek treatment, which might affect their schooling, even their future career opportunities. It poses a much bigger question. That's the right to live with dignity, which is our fundamental right in any civilized society. Those diagnosed with the disease face difficulties in marriage prospects, education, employment opportunities, accessing nutrition and social isolation, besides enormous and deep contempt by the society. They are subjected to extreme persecution and social injustice and receive little or virtually no support in most cases. There is urgent need to intensify advocacy by elected representatives at all levels. As we understand, the lawmakers can impact policy and raise the level of discourse among stakeholders. We also need to continue to sensitize the policymakers right down to the last panchayat in this country. Even the members of legislative assemblies, the corporators, and all constitutional mandated panchayats must be taken on board for spreading awareness. We must also use services of celebrities and other society influencers for a nationwide concerted campaign. Friends, there is a glaring absence of patients' voice in our TB control initiatives and subsequent lack of understanding of the patient experience. The voices of those affected by TB matter more because they break through pre-existing perceptions and provide real experiences and needs of those that have survived TB. Community structures such as Mahila Arogya Samitis, various self-help groups, and local volunteers can also be effectively engaged, trained, and incentivized to generate awareness and facilitate socioeconomic support to TB patients, and also to empower communities to be TB-free. We need to work on innovative communication strategies and step up community mobilization to reduce stigma and social discrimination. Besides, also encouraging investment to reduce gender-related disparities, we also need to build coalitions with civil society, NGOs for local advocacy, and also expand services for home-based palliative care for TB. We've seen recently during the pandemic how brilliantly and commendably have the ASHA workers handled everything. We need to expand the pool of health workers by capacity building and also provision of appropriate training, and also by enhancing their means of sustenance and administrative support. I'm sorry, they're paid very meagerly. I brought it to notice of the health minister a couple of months ago. And you cannot sustain a force like ASHA, who done so well in this pandemic, only if we expanded them by 500 or 600%. I think they'll be able to take on anything and also render enormous assistance for at least palliative care at home, all services at home. And we experienced what is phenomenal success they have conducted themselves with. To mitigate suffering of women with TB, I would like to conclude that we must adopt holistic approach with multi-sectoral coordination, expand use of ICT, strengthen our political will to make our response patient-centric, community-led, rights-based, and gender responsive. That is all I have to say. Thank you, ladies and gentlemen.
Thank you, Dr. Singh, and thank you for starting this off by really laying the pillars of not only how this conversation should go, but how we need to work together. I'm also very proud to say that we are joined by a lot of people who are actually the community level workers. They are in this conversation in the audience. I'd like to welcome them again. I can see some hands being raised, and again, I'll just like to request that if you have any questions, leave it in the question box. We'll take it up towards the end, but a very warm welcome to the people who are actually working at the grassroots. With that, I'd like to turn to Dr. Joshi. Dr. Joshi, welcoming you again to the conversation. Dr. Joshi, can you hear me?
Yes, madam.
Okay. Dr. Joshi, welcome again. And, just keeping the background of the conversation in mind, I wanted to know from you. Recently, the NTEP has published two very pertinent and timely documents, the National Framework for Gender Responsive Approach to TB in India and the Strategy to End Stigma and Discrimination associated with TB. Both gender and stigma need to be central to the responses that we create. It is crucial that these are effectively operationalized to see real change at the ground level. And like I said, we have a lot of grassroots level workers with us in this conversation today. What are your strategies to do this? And how does NTEP aim to take it forward, sir?
Thank you, Dr. Chauhan. Good afternoon, all. And firstly, thank you for giving me an opportunity to participate in this very, very important. This is one of the aspects which we are actively looking at. And I personally feel it is one of the things we have to do. It is the right of the people and the community that we address it. Secondly, my greetings to all on the eve of International Women's Day. I think this topic chosen by Khpt is very apt on this point. Like Madam just said, the National Tuberculosis Elimination Program has been looking at it, and recently we have brought out important guidance documents. One is the National Framework for a Gender-Responsive Approach to TB in India. And secondly, Strategy to End Stigma and Discrimination. The gender-responsive approach to tuberculosis in India is designed to look at all aspects of the TB, both from the workers involved, whether they are adequately represented at all levels, to the care given to the TB patient, right from prevention, detection, treatment, and follow-up. Whether it is treatment rather than follow-up. At all levels, we want to give equality to women, because gender is something which, unfortunately, even in urban areas, we find that there is a possibility of discrimination at many levels. Rural areas also we have seen. And India is a diverse country. We have got huge cultural and geographic variation. And in some areas, it seems quite significant. So we want to look at it and build the capacity of our workers at all levels to respect women, transgender, and to involve them in their day-to-day decision making, guide them correctly, and see that there is no discrimination at any level. So this becomes much more important when our workers visit the houses. So we have to train them to be respectful to the women, be sensitive what questions they ask in front of everybody, and take them into confidence. And they should also see that there is the same care and respect is given at all levels. Then we are also trying to involve the community in a big way by making separate groups of, say, people who have survived and won the tuberculosis, whom we call TB Vijeta or TB champions. And I am happy to say that there are a lot of women who are now have got the confidence to come out and tell the community that yes, I had tuberculosis, I took correct treatment, and now I have come out of it. You people can also do. They are helping the community. So these things from each angle, whether it is the detection, treatment, prevention, or capacity building, at each level we want to see that there is no gender discrimination. We want to improve it. So the document itself is fine, but we want to see that it is fully operationalized and implemented across the India. And really thank all the partners who are working in this field, who are actively helping us to achieve this. Stigma, even though tuberculosis is one of the oldest diseases known to mankind, we say that no, it was present in the mummies, Egyptian mummies, it has been detected and all. But even in the information era of 2022, we still feel that there is a huge amount of stigma, whether it is at home, workplace, or especially when it comes to gender and issue, the girl may hesitate to reveal it so that marriage or their in-laws may discriminate, marriage may not occur. Lot of things are there. And in workplace also, we have seen a lot of stigma. So we are again actually involving the multiple sectors. Recently, we had a talk with the corporate sector where we created awareness them that this actually happens. So you see that your workplace is free from stigma. If somebody has got tuberculosis, he should have every right to know that what are the facilities available, but he also should have every right to feel that there is no problem. He can reveal it to others. He can work with. Now we have got very good medicine. The person becomes non-infective, even though a put-up positive person. Once we start the treatment, they rapidly become non-infective. But that stigma has to go. You should feel confident. So we are trying to involve it in our community workups. We are trying to involve it in our corporate sector. We are trying to involve with other interministerial workshops where we tell them in your workplace, in your offices, you create awareness so that there is no stigma attached to it. If somebody has got a heart attack or he undergoes a stent, nobody hesitates. They tell proudly, yes, I spent 2 lakh, 3 lakh, 1 lakh on stent. I went to this hospital. It looks like as though I've done a great thing by undergoing a PPCOH stent. I want the same thing to come to tuberculosis because it is much more simpler disease. And even though it is infective, once treatment is started, patient takes treatment, they are no longer infective. So that stigma has to go. So this again, we are trying to make it and involve community level as much as possible. Material, whether we involve another thing we are looking at is involve the local leaders like Sarpanch, the members of the village panchayat and all. So we want to keep this spreading the awareness, scientific facts across the community using all the media possible, including social media, so that stigma has to go, gender equality has to happen. So I'm very sure that with the help of all the people who are today participating in this and all our partners, NGOs, and the government machinery, we are very sure that I'm very confident that we'll definitely do away with the gender discrimination and the stigma as far as tuberculosis is concerned. Every person has got a right. It's not that we are doing something extra. It is their right which we should have done and we are going to do. So with this, I assure that the Central TB Division is definitely aware of this and actively to support the initiatives towards this ending this discrimination and stigma. So again, I thank the organizers for giving me this great opportunity to participate and tell a few words. Thank you. Over to you, madam.
Thank you, Dr. Joshi. And like you said, stigma has to go and gender equity has to come in. And I think I can speak on behalf of all the panelists and the audiences logged in. We are here to support you and we are going to look forward to your leadership, KHPT, along with all partners, sir. An honor to have you again on the conversation. Thank you so much. I know that there are some questions for you, sir, which I will be asking you towards the end of the webinar and towards the end. And actually, we'll want the audiences to ask those questions to you. So I hope you'll be able to stay with us and thank you once again. Pleasure to have you. With that, I'm going to move to Miss Amy Piatek. Amy, welcome once again. And, we want to actually understand from you that how can we encourage and sustain a gender-sensitive TB response by ensuring prioritization of funding requests that include gender and equity considerations? How has the USAID planned to address this now and in the future? Over to you, Amy.
Thank you so much. And thank you to KHPT for holding this very important webinar honoring women and honoring, all of the work that has been done by our colleagues, out in the field, in India and in every country. It's such an important discussion, such an important topic. But you're right. If we don't have the resources and the funding and the capacity and the staff, to do these things, it's really just words, right? So I am really happy, that USAID has made this part of our institution, and has really prioritized it over the last few years. It's been a policy of ours for more than a decade, but we've really seen, I think, a transition and a bit of a transformation in our policies, on the ground and our projects. Yes, this is coming from USAID, but it's really coming from our teams in countries. It's really coming from our partners, right? Our partners are asking for it. Our partners want to have the ability to be able to implement these really important activities, and not just to, for women, for girls, for these vulnerable populations, but how can they partner with them together? How can they really bring them into the planning of activities? How can they really have them part of the decision-making process for, this is what we're going to do, this is how we're going to help. So, I think my colleagues before, my esteemed colleagues, have really laid nicely out, what are the challenges, especially in India. And, we have seen that unless we prioritize communities, unless we prioritize women, unless we prioritize these vulnerable populations, we will not see movement on our TB goals. And we have started seeing improvements in case notification. We have seen improvements in treatment adherence because we are specifically targeting these populations. I think that if COVID has really given us any lessons, it's that unless we have these strong links in our communities, especially when we have these lockdowns, we don't have the ability to get into some places, we're not going to see any changes. So, as I've stated, USAID really is committed to supporting the rights of women and girls and other vulnerable populations, not just in India, but across the world. We try to bring our global leadership, our technical expertise, our strategic partnerships to be able to achieve the overarching goal of ensuring equitable access, opportunity, and benefits for all. We have a global network of more than 180 gender advisors and points of contact throughout the agency, including in India. And we work together with our other USAID colleagues to integrate gender and advance gender equality objectives in all of our work. Like I mentioned, we do have a gender equality and female empowerment policy. And it's true for also like our TB activities across the different countries that we support. There are just a few of the guiding principles that I wanted to highlight. The first is integrating gender equality and female empowerment into USAID's work. So like I said, this policy, it will be implemented by integrating approaches and actions to advance gender equality and female empowerment through our entire, what we call our program cycle. This is from, determining, what are the priorities, how do we develop and design different projects and and bring in different partners to be able to carry out those programs. And we have made some strategic investments, in this area over the past years. Another is pursuing an inclusive approach to foster equality. So this policy is inclusive of all women and men, girls and boys, regardless of age, sexual orientation, gender identity, disability status, religion, ethnicity, socioeconomic status, and those types of populations. And the last principle that I really want to highlight, which I think is really key to this, is building partnerships across a wide range of stakeholders. And this is where I think if you look at USAID support, especially in India over the more than a decade, you can see how it's really evolved. We have really prioritized partnering with governments, especially our colleagues within the Central TB Division, civil society, private sector, and other donors to ensure that our efforts are coordinated, they're not duplicating other efforts, and they're building on the skills and initiatives of local actors and reflect country priorities. So we have really made a concerted effort over the last several years to partner directly with local organizations in our countries to implement locally generated solutions. And I think this is key to improve TB diagnosis, treatment, and prevention services. It's not coming in with a pre-arranged agenda that USAID has across the world, but really saying, what is it that India needs? What is it that we need to support women, girls, these other populations to make the difference? It's one thing for USAID to have these policies that prioritize women and promote gender equity, but it's much another thing to make this a practice in the field. But we can see, and I'm really proud of the work that USAID India has been doing for the last several years. USAID supports several Indian organizations working in TB, including Khpt, the host of this webinar. And we expect that all carry out their work addressing gender issues, identifying gender inequalities, and targeting interventions for women. And we really do hold all of our partners accountable to ensure that activities reach the most vulnerable and marginalized sections of the population. But I mean, the real thing is that we as a development agency has to hold ourselves accountable. And it's by having these types of webinars and continuing to discuss and hearing from all of our colleagues that we continue to do so. So with that, I thank you very much again for including USAID in this conversation, and thank you.
Thank you, Amy. And like you said, it's actually the communities that we need to work with, learn from, and very happy to say we have about 250 attendees, and many of them are the people at the grassroots. So thank you for your words and the encouragement, and we look forward to continue to work with you to hopefully enable impact. Thanks, Amy. Dr. Luchika, welcome to the conversation. As always, a pleasure to have you. And I think people, who are logged in would really like to know from you that how is the Stop TB partnership promoting a gender-sensitive TB response across all levels, from the highest to the lowest, and what has been the biggest challenge you have faced in doing so?
Thank you so much. Yeah, it's actually, I'm very happy to be here. In a way, we are in the year 2022, and I hope we were planning to get full speed back on track. Realities on the ground are not really leading us to this. We are faced with completely unexpected challenges. This year's, I think we are all, we are like these boxers in the ring. We get hit from places that we didn't expect, but I find this gathering amazing, and the fact that not only we have almost 260 people online, but also because it's tackling a topic that is very important and that suffered a lot because of COVID. As Stop TB partnership, since many years, we try to push the agenda that is gender sensitive, that is inclusive. We were pushing, the entire set of tools for the community rights and gender assessments. And a lot of assessments, 20 of them took place and developed as well very solid actions to take forward the findings and to really address them. Then I have to admit that for all of us, I think COVID hit us, and there is something that COVID hurt in TB beyond the epidemiology, beyond the people lost, beyond the obviously people that lost their lives. I think on the aspects of rights and gender, it turned us back. It showed a very big difference in how people have access to care. And as well, it showed the vulnerabilities linked to gender and belonging to a certain gender or a group. All these vulnerabilities that are in front of accessing services and accessing diagnosis and treatment. So as Stop TB and pioneering, because you said what we were doing, we have a very robust set of tools to do gender assessments at country level. and then to be able to identify what kind of issues will need to be addressed. We also supported, and I'm very proud of that, and I think some people online here, a network called TB Women, which last year for the World International Women Day launched their strategic plan. And we are very proud because them as a group, but also several members from them are also being able to access financial support as grants from the Challenge Facility. So that is really amazing what is going on in terms of the trying to empower women, transgender, and other groups really to become vocal and at the center of our efforts. We will continue like this in Stop TB. We will continue also to push, obviously, that there is a proper representation of gender into the decision maker bodies in not only at the global level, but at regional and at national level. And very important at the national level, you see when different policies, national strategic plans are developed without having the right people around the table, not in order to tick a box, but really to be able to really to get really engaged, to be the ones crafting the projects, crafting the areas of work, implementing as well as monitoring. It will never happen in the right way. Nobody can put themselves in the shoes. A man can, as much love and empathy will have, cannot put himself in the shoes of a woman. We cannot put on the shoes of a transgender. We can never craft interventions that are proper without having those that are the recipients of them at the table. And you asked what are the challenges that we faced. I will tell you there are two. One is the barriers and the mindsets of people. And in some instances is because there is not enough dialogue. In some instances is because people don't really understand. In some instances is because they don't care. And for me, I think the lack of empathy and love and support in public health in general, I think it's what arrived us where we are, including during the COVID era. You know, it's incredible that for me, I think all the situation with the access to vaccines, in which you have developed countries hoarding tens of millions of doses without allowing other countries to get. It's an example in which you lose completely trust in what's going on, because you see this. How can you trust that women, people of different other religion, different sexual orientation, different the poverty level and so on, how can you expect to be empathy at a smaller scale if at a global scale is so much in your face that is social injustice? And then the second barrier is not only on the perception, it's a more dramatic one, a sad one, is the lack of resources. People, when you don't have money, traditionally in TB programs, money are never enough. We barely have half of what's needed. And when you try, globally in the global fund eligible countries in 2020, we had 32% of funding available, 68 missing. When you have just 32% of the funding, what happens is that decision makers will need to
Dr. Ditty, you just lost your, go ahead. You just lost you for a few seconds. Go ahead, please.
Okay, I just wanted to say that when you have just 32% of the funds, decision makers, what do they have? They have to prioritize. And to prioritize, they will start cutting things that are not that important. And sometimes it's because they don't have enough money even to secure the pills, the treatment, leave aside the diagnosis. So my appeal and my point that I want to make here is to really make a comprehensive national strategic plan. To really have a good TB response, we really need to consider all these factors in there. We need to consider all these barriers related to creating a program which is gender inclusive, and they need to be addressed, and they need to be budgeted. And we need to raise our voice, all of us, but starting, and I'm very happy that we have so many colleagues here online that are to raise the voice that these are not the forgotten pieces. And without having a plan in which, not a plan, without having the the thinking to request the right money to address this. There will never be anyone. The Minister of Finance will not stay there saying, oh, we need to give more money for TB because the gender aspect is not properly addressed. Nada, it will not happen. It's a huge fight between health and other priorities in a country, but there is a huge fight within the health priorities. So the challenges are related to our embracing and understanding of the gender aspects. And as Stop TB, we will continue to push this through Challenge Facility and through implementing and supporting countries to do the gender assessments. But the other big part is related to the finances. And again, there should be no national strategic plan. There should be no application to a donor. There should be no Minister of Finance approach for funding without including the different aspects that are needed for a comprehensive and round TB response, including and obviously centered on civil society and communities, but including the gender aspects. So that's what I want to say. And thank you very much for this. Thank you.
Thank you, Dr. Ditty, and always a pleasure to hear from you. And thank you for letting us know your thoughts. And we continue to look forward to your guidance, working with Stop TB partnerships, supporting to really bring in change. This brings me to Ms. Blessina Kumar. Welcome again. And just wanted to know from you that in your experience of being in close contact with people affected by TB nationally and globally, what has been the progress so far, and what are some of the things that need to be addressed going forward to ensure gender equality today for a sustainable tomorrow?
Thank you very much, Sukriti, and a very good afternoon to everyone. I want to also join KHPT in welcoming you as one of the co-organizers of this. A very special welcome to our members who are joining us from out of India. And also very special welcome to all our Touched by TB champions who have joined, registered and joined. Aap sabko meri taraf se bahut pyar bhari welcome. Hope we will be able to translate this at some point, maybe give you the highlights. So I'm really humbled to be one of the panelists with such esteemed colleagues here. Gender inequality and systemic discrimination against women, girls, and gender diverse people is an international phenomenon, that manifests in every aspect of life. And we know that TB affects more men than women, but we also know that TB affects women disproportionately, and the implications are far more severe. Reproductive health, malnutrition, all add to the barriers, and risk to maternal and child health, neonatal health are really quite devastating. So GCTA, our capacity building trainings of over 400 TB affected community members across the globe has time and again shown us what the barriers are along the cascade of care. And they are not what we expected. One was stigma and discrimination, lack of awareness, lack of counseling, and these really stop them from accessing care. And right now we are in the process of putting together a gender TB and gender fact sheet, gender equity guide to building a sustainable tomorrow, and along with partners may be able to launch it very soon. And I do want to quote one of our partners from that, who says, stigma stops transgender people from accessing appropriate care for TB. We need multi-sectoral commitment and action to ensure care models that specially cater to the needs of the transgender population. We cannot build a sustainable tomorrow without investing in robust mechanisms to break gender barriers today. This is Abina, one of our very dear partners, a transgender woman who's been very vocal and a leader in the community. Now, addressing stigma, a lot of us have talked about it, and I'm very encouraged actually to see the consistent commitment of USaid. I remember having met Administrator Green a few years ago and speaking to him about this. and how passionately it was taken up and rolled out. And I want to really say a big thank you from the communities for that. And that has enabled many partners such as KHPT to really take on the baton and run with it. But addressing stigma and discrimination really needs a shift in the way we think. You know, not just people on the ground, but even those of us who are providing care, the healthcare workers, need to think differently, because we end up discriminating and stigmatizing people who seek care many times. Lack of awareness is another thing that people have brought up to us many times. You know, this TB journey is very frightening and a very lonely battle. And fear reinforces the stigma, because lack of information, lack of what you're going through in your body causes a lot of fear, and that reinforces stigma all over again. And one of our members, who's also a governing body member of Touched by TB, Prabha, has repeatedly told us that there is so much of ignorance, not just among the community, but even among doctors. And they need to explain the disease better. They need to understand that people with TB are going through anything else to be able to identify it. And she said, we actually need a checklist with indicators. It has to be a systemic process, and counseling needs to be done accordingly to address specific issues each individual's face. And I'm quoting them because panelists and others have said that it's important to listen to the affected community. And as I said, TB can be a very lonely journey. Counseling is really crucial. Someone to hold the hand, someone to be at the end of that telephone line, encouraging and supporting. And we know that through the Champions program, we know how successful this has been when someone who's gone through the disease is able to support you. And also access medical care and support, especially TB care and support, needs to be really accessible to people. And many of these things, I'm talking to the National TB program, and I hope Dr. Joshi is hearing me. You know, it needs to be accessible for women so that they are not dependent on someone actually having to take them to the center. Needing permission, needing to make elaborate plans, whether it is to take care of home responsibilities or take care of children, or having to spend money for travel. I think TB care and support should be made so easily available, as easy as buying groceries or a bar of soap. I think that's when it will make it easy for women to access it. Empowering the last mile is very important. We know that people tend to go to the first point of contact, whether it is the ASHAs, the ANMs, the Jolachap doctors that we see moving around in the rural areas and the slums. You know, they need the right information. They need to be brought into the fold and given the right information so that they can provide the right guidance and support that is needed. And an enabling environment is really important. I learned many years ago when I started my community health practice that in the villages, we used to call it something called around the water well. Women used to gather there to draw water and put their pots aside and sit down and have a chat. And we found that that was the best place to actually talk about health. I know times have changed, we progressed a lot in the past 30 years, but we need to find things like that where women come together, and women actually tend to use those opportunities to share challenges and successes. And lastly, I think the National TB program needs to operationalize the national strategy on addressing stigma and discrimination associated with TB. How do we build capacity of the state TB officers, district TB officers, communities to understand and put this into practice? And those of us like KHPT, the Global Coalition of TB Advocates, who've all been part, and USaid, who've been part of developing that, I think are committed to help operationalize this and support you in this. Now, just a few words to civil society organizations, what you can do. Now, many of us working on gender submit proposals to transform the TB response and have received funds for it, ample funds for it. Our proposals are developed by consultants, very clever ones. That's very good. But at times, I feel that there is a lack of understanding or little understanding of ground realities and realities that affect women and other groups. Now, our experience as GCTA is that we need to move to a place where we should have focus group discussions, key informant discussions to understand what women want or what other marginalized groups want, not what we perceive the want to be. So to truly understand what system would be suitable and acceptable, and then incorporate that and build a proposal around it would be very important. Our implementation will become more transformative. It would get us better results and better value for money if only we did this. Inclusion and place at the table are crucial if we truly want to see a transformed TB response that is gender sensitive and equitable. It's not easy, but it's not an option either. So we need to really move towards making that people-centered, rights-based TB response a true reality if we want to end TB. Thank you.
Thank you, Blessy. As always, words that we are going to follow, work with you, and thank you for co-hosting this with us. We are honored. I know a lot of the community workers are workers who work with you, a lot of survivors who are led by you. So thank you once again. Like you said, it's not easy, but it's not an option. And I'm going to reiterate that for everybody on the conversation today. I'm going to turn to Dr. Sachdeva. Dr. Sachdeva, welcome. I just wanted to check if you can hear me. Thank you, sir. Thank you. Thank you for being here. Always an honor to work with you, have conversations with you, sir. Today, we just wanted to know that what are some of the interventions that the I Defeat TB project implements to create, sustain, and accelerate for a gender-sensitive TB response in India. Also, how does the technical support extended to NTEP India encompass a drive to ensure gender equality today for a sustainable tomorrow, sir?
Thank you, Sukriti, and all other esteemed panelists. It's an honor to be associated with your webinar, and specifically on a topic as sensitive and as the need of the hour, which is a gender sensitive response to TB, breaking the barriers. I mean, it also gels very well with the theme of the International Women's Day. We all know that epidemiologically we say that men have more TB than women. In TB we say 2/3 men are affected by TB, 1/3 women are affected by TB. But we have seen wherever you try and extend your reach, be more sensitive and responsive, you find more women. I mean, you tend to find more women who also have TB, who are not routinely diagnosed by the routine passive reporting system of the program and other measures. So and that's well documented in literature also. So if you search for TB in women, you will find more and more TB than you expect epidemiologically to be. So that's a stated fact. We have seen that being addressed. I've seen a change in the program from being gender agnostic. Initially, we said we don't differentiate based on caste, creed, economic status, etc., to being gender responsive. And also now seeing that there are targeted interventions under the program and also under various projects, including ours under I Defeat TB, where we try to seek more TB, more support to the women groups in general to find TB and address, because women are also part of a larger family, and they are also caretakers to children and also other people around. So I see that clear shift from gender agnostic to gender responsive to some of the targeted intervention. And reference was made to 2 frameworks being released by National Program on Gender Responsive TB in India and Strategy to End Stigma and Discrimination. Add to that, what I'm saying is that the program has also produced 2 more documents. One is on women and TB, and the other is on pregnancy and TB. So they are the proof of the pudding is just that your advocacy is working on field, is that you see these 4 documents now being produced in last 2 years, whereas the program is so-called running from 1958 and 59. So after all, the advocacy and the work by your groups and many more such advocates is bearing, seeing the light of the day, and things are changing. The same change you see within the various projects that we implement at the union, including the USaid supported iDefeat project. Within our project, we have various components on blended training and capacity building, the centers of excellence, the program on strengthening the laboratory, supply chain management, reaching out to the patients. Also, we have a union conference, and believe me, in our organization, at the higher level, you find disproportionately higher number of women executives compared to men executives. Today, only at the lunch table, we were talking that in the senior management, we have just 2 men here, myself and others, Dr. Rana, and the rest all senior management is women. So we have, as an organization, we are very gender responsive, to say the least. So as an organization, we have also worked at some time to eliminate stigma and around TB. We continue to work on areas of eliminating stigma around TB. Some of you might recall once there used to be a campaign called Balgam Bhai, where you tried to normalize cough in the general discourse, because this is something which people don't talk about it. But so we did try to normalize cough and reduce stigma around those coughs. So there are concerted efforts to reduce stigma, a concerted effort to reduce discrimination, and we see to it that all our programs have rather targeted interventions for women and also the children and other this thing. The another proof of the pudding is that your advocacy and advocacy by many other partners have resulted. If you recall, there used to be, there always had been a subject on pediatric TB, but now you have a subject on women and TB under the National TB Elimination Program. And that's also a very, very recent development. It's not, you can't look much far back into the past and say that it always existed. It's just a 2-3 years existence that you have a separate focus on women and TB. So having said that, congratulations to you and your team on bringing out such an apt topic.
Thank you.
So we don't also look at gender in a binary sense. We also, I mean, we are addressing it on a women on the occasion of an International Women's Day, but we also, through our advocacy and your advocacy, the program also captures the other gender. I mean, we don't always look at gender in the binary sense. That's what you have also alluded to, but all in all, huge congratulations to you. I'll be available for questions and some clarifications. Yeah.
Thank you, Doctor. Thank you, sir. Thank you always. And gender should not be in the binary. And a very important takeaway message from that. We have about 20 minutes left, and I want to make sure that as many questions that can be posed come in. But before that, to just close this panel discussion before we move to questions, I want to turn to Dr. Rehana. Dr. Rehana, how are you working with communities affected by TB, especially the most vulnerable and marginalized pockets of the populations, to ensure that a gender-sensitive response to TB can be made a reality in India? What are some of KHPT's learnings from the field? And as you're leading the Breaking the Barriers, we'd love to hear from you, and we have partners who have joined.
Thank you, Sukriti, and thank you everyone for joining today. We have the privilege to share our experience on gender equity with you on this important platform. KHPT is implementing Breaking the Barriers project funded by USaid in Assam, Bihar, Telangana, and Karnataka, and uses community engagement to accelerate the TB elimination efforts in India. The project focuses on promoting the health and well-being of the TB person and the caregiver community in an enabling environment. And one of the major components of this project is to develop and implement behavior change solutions for specific vulnerable populations groups to overcome the barriers to TB diagnosis, treatment, care, including stigma reduction and gender inclusion. And I just wanted to give an example here that there was a study from AIMS in which only 37% of the women had access to healthcare compared to 67% of men. So access to healthcare is therefore still a challenge for most women in India, especially the marginalized communities. The vulnerable population groups covered in this project are urban poor, tribal, migrants, mining, industrial, and tea garden workers. So I was able to connect our project experiences to the valuable experiences shared with the panel members on this forum. And some of our key observations from this field show that tuberculosis affects women directly or indirectly. Directly if they are infected by TB, and indirectly if, as most often, the caregivers of the TB person would be in women. Access to clinical or extrapulmonary tuberculosis diagnosis is a challenge in women. In these cases, sputum would be negative for TB and require further investigation at a higher center. So in spite of that, traditionally, women tend to have better adherence and treatment outcomes as compared to men. The pressure to get back to work and the lifestyle habits such as smoking or consumption of alcohol influences the discontinuation of the treatment in men. And we have also identified that the transgenders appears to have more barriers with regard to TB care than TB infection per se. So based on our past experiences and gender responsive NTEP framework, we have a gender-based plan for the project. We are trying to identify ways and approaches to marginalize the strategies outlined to address gender inequity and have a bottom-up approach from communities upwards. So at the field level, we are working with community structures, several of whom are women-led, like Jivika, self-help groups. We are including gender sensitization in our perspective buildings and on routine handholding meetings of these community structure leaders. So stigma with respect to TB is being handled by our project and also the NTEP staff and community structure leaders. For example, if the families are not receptive of TB patients, they counsel them and provide necessary support through linkages. And we are also ensuring participation of women and transgender persons in the platforms where TCs are involved, like TB forums, and engaging them with the communities, etc. So some of our behavioral solutions are supporting women with TB. For example, the TB R2 supports in access to clinical diagnosis and extrapulmonary TB diagnosis of TB in women. And the TB buddy solution helps women with tuberculosis in their journey towards a treatment completion. And another solution called Phone Friend, which is keeping in the anonymity with which a woman TB patient wants to have. A Phone Friend solution has been very promising to kind of support these women in their treatment adherence and also in their providing them with emotional support. So, and also given that most of the TB caregivers are women, our solution TB starter kit has been found to be very effective in providing caregivers with the necessary perception. So this will definitely help them in providing the necessary support to the TB patients. And our patient-centric approaches are helping in addressing gender determinants in TB care without additional burden to the healthcare providers. And also finally, like, information like disaggregated according to the age and gender is helping us to better plan programs, and ensuring that adequate representation during assessment is helping us in understanding the situation and identifying solutions. So all of this is done at the grassroots level, at the bottom, at the community level. And at the project districts, we are ensuring that the health workers are trained in gender dimensions. And as rightly pointed out by Dr. Joshi sir, that it is important to ensure that the healthcare providers have the necessary, have been trained to be gender sensitive. And also, like, there we are like ensuring that there is integration of gender in RCH, like services like reproductive and child health. So at the national, we will be assisting in implementing of the gender inclusion framework in line with the vision of the Ministry of Health and Family Welfare and the NTEP. So these are some of the approaches we have in terms of, in our project, in terms of gender. And our experiences show that communities have an immense potential for building awareness and providing health-seeking behaviors. The resilience that displayed by these communities has been a real learning experience. So I would like to just end up by saying that gender inclusion in the community through the structure, leaders, and members is a vital step in ensuring gender equity. Thank you so much, and over to you, Sukriti.
Thank you, Dr. Rehana, and proud to be part of the team and working to make a difference. So happy that our teams from the 4 states and beyond, and like Blessy said, with lots of survivors have joined us today. Before we go to the question answer round, I know we have about 15 minutes to go. There is a message from Ms. Veena Reddy, who is a Foreign Service Officer who arrived in New Delhi in August 2021 to take charge as the Mission Director for USAID. It's a message for International Women's Day, and we'd love for everybody to hear that. She has a rich background in development and diplomacy in her role as the Mission Director. Can I please ask the team to play the video now?
Namaste from USAID India. Today and every day, we reaffirm our commitment to advancing women's empowerment and gender equality and equity. Today, women are leading the way in technology and science with breakthrough innovations in a number of fields, including health, education, and finance. Together with our partners, USAID enables women to succeed economically, expands women's dignified access to reproductive and other health services, promotes the rights and inclusion of the LGBTQI community, ensures women leadership and meaningful participation in all areas of life, and advocates for policies to be more gender sensitive and gender inclusive. We also work with men and boys as key allies and champions of gender equality and women's empowerment to achieve sustainable and long-lasting change. Over time, we've learned that investing in women and girls is essential to transforming communities. When women do better, families do better, communities do better, and countries do better. Join USAID as we celebrate women and girls in all of their diversity.
Can the team stop sharing the video? I'm sorry we couldn't see her, but we could hear her. And I think we need to work with USAID as partners together to bring in change. I'll make sure the video reaches everybody. I'm sorry for that short technical error, but glad to hear from Ms. Reddy. I'm going to open the floor and I'm going to actually turn to Fez. Fez, you have a question for Dr. Luchika. Would you like to come in?
Yeah, hi, this is Faz from Hazaribagh, Jharkhand. Hi, Luchika. I have a question that in this gender-specific talks, are we neglecting men-specific like programs? We are having a special program for women and transgender, but we are not having any special programs for men. So, are we neglecting them, or is it impacting a certain level of orientation at men's? To the male part.
Yeah, thank you so much. You see, It's a good question that you brought up. You see, and you are not the first one that you asked this, because Dr. Sachdeva started speaking about the fact that let's recognize that TB affects more men, you know, than women. That's the pathogen, and that's how it goes. But it's like Mr. Faiz, it's like in a race. Women and transgender are starting from way behind in terms of access, in terms of inclusion, you know, and that's why we need to focus till we arrive at somehow the same starting point with everybody in this point. But when we speak about gender, so that's why, let's say, there is a focus now over the last years in trying to basically catch up and ensure that the services are inclusive. But in a normal program, you need to speak about people with TB, everyone. You don't need to make the differences. But you see, it came out that the way that the services were constructed and the access were very much, and the society is constructed in many places, it's very easy to navigate the health system, or it's easier to navigate the health system for a man than a woman in many places in the world. The access to the service, the perceptions, the norms of the society are towards women much more difficult. In my own country, I have actually, and sadly, countless examples of women who were abandoned by their husbands just because they had TB. Very rare is in a different situation in which the women left the men with TB, you know. More than that, I think they are always taking care and so on. And for transgender, the things are even more difficult. So we should not neglect anyone. That's the line. We cannot leave behind a single man, a single boy, a single girl, a single woman, a single other gender orientation and so on. But we need to see which are the ones having more vulnerabilities. This is what the gender assessment tool is, to identify. Maybe in some countries, actually, I don't know of any, but men are in that situation. So you do an assessment, we see where it is, and then the ones that are having more barriers, being them men or women or transgender or children, will need to be supported to overcome those barriers. Thank you.
Thank you, Faiz, and thank you, Dr. Luchika. I know there's a question from Tess Keem to Amy. Tess, would you like to come in?
Yes, thank you. Thank you so much to all the panelists for your really inspiring and powerful presentations. My name is Tess and I support TB programming in PNG. And my question was to you, Dr. Amy Piatek, just in your experience of supporting TB programs across the world, do you have an example of an action or a change that you've seen implemented by a TB program or multiple TB programs that has made a really clear impact for women or people who are gender diverse?
Hi, Tess. Thank you so much for the question. So I think that kind of broadly speaking, about 2 years ago, we had a switch with our USaid strategy. Now we're calling it the Global Accelerator to eliminate TB. And this has had a big switch in transformation to focusing to support local or in-country organizations, and also much stronger ability to partner directly with the national TB programs. In doing so, this has allowed us to have a much more direct partnership with communities and women on the ground. So I can't think of like a specific example, but what we've seen is just a lot more advocacy, you know, from our USAID missions and partners for including women in kind of the design and implementation of their activities. So, you know, I'm happy to kind of follow up with you on some more specific examples. But I think just in general, this has been, you know, not just something that has helped, for example, like women and, you know, transgender and other populations, but really looking at, migrants, internally displaced, indigenous populations. I think kind of in general, what are those real populations that need to be targeted in a number of countries? And by working directly with people on the ground, this is how we get to know what the priorities are. So thank you for your question.
Thank you, Tess, and thank you, Dr. Remy. I know we are joined by Prabha Mahesh, who has a question for Dr. Joshi. Dr. Joshi, are you with us? Okay, I will get back to that, Prabha, for you. In the meantime, there is a question by Prasenjit for Blessina. Prasenjit, would you like to come in? Could you unmute yourself, Prasenjit? Go ahead.
Yeah, namaskar once again to everyone, and thanks to the expert panelists for the excellent dissemination of your thoughts. Sure to really improve my learning curve. Madam Blessina, I would like to know we have a timeline, by 2025 we have to show that this mission can be achieved. So what, according to you, are the key barriers that need to be, number one, collectively prioritized and then addressed by both the government and the civil society partners like us, going forward to ensure there is parity, gender equality in TB response in the days to come in a much sustainable manner. Thank you so much.
Thank you so much, Prasenjit. In terms of barriers, like I already mentioned, listening to the people who have gone through this very arduous journey, actually people want to be treated with dignity. People want to be able to want to go and seek care. But right now, stigma and discrimination, complete lack of awareness of what TB actually is, and someone to support you through that is keeping people away. That 4 million people that we continue to say are missing, how do we bring them in? Perhaps we need to pay attention to this. As far as diagnostics, drugs are concerned, I think the wheel is moving. Yes, we still need to advocate for safer drugs. We need to advocate for those who are approved to be rolled out really urgently. So that is taking care of one part, and that's moving. The wheel is running. But where we are getting stuck is this people-centeredness. And I think India is the first country to develop a national strategy to address stigma and discrimination associated with TB. And I think that's, it was done when Dr. Sachdeva was the DDG, and now Dr. Joshi has taken over. And we really hope that this really is taken seriously and doesn't just sit on a shelf catching dust. We need to unpackage this urgently. We need to make some sort of a tool out of this to train the people who are delivering care. People affected by TB. Unless and until we make it a place people want to come, they will refuse to seek care. And we are not going to reach 1 billion people individually to make them come. Make it easy. How can we make it easy? Let's learn from private sector, where for every product to sell one product, they shake the world to ensure that people come to know about it. The prices are affordable, it's accessible. I mean, I can think of 100 things which are really bad. Pepsi, and various other things. Maggi noodles, you can get it in any remote country or village of this country. It's not very good. Why can't we make TB care services as accessible, as empowering for the person to get, rather than being treated as someone who is literally almost not to be spoken to, not to be touched. Till today, we get phone calls about this. 2 days ago, I got another phone call about this. So it hasn't gone. We haven't gone away. So prioritize addressing stigma and discrimination and provide care that upholds the dignity of the individual. Thank you.
Thanks, Blessy. Thanks for the question, Prasenjit. I know we are at 1 minute to go, but I'm going to request everybody for just 2-3 minutes more, because I know, Dr. Sachdeva, there's a very young person from the field who wants to ask you a question. If that's okay, may I proceed? Ashita, please go ahead.
Thank you, Dr. Chauhan. My question is, so you said that gender is not a binary. How do we consider different social factors for women at the lower classes or marginalized communities for effective TB response?
That's the very fact that we are discussing gender responsive framework is that because we feel that there are different social contexts and factors which influence the health-seeking behavior of women in the community. I said it's not binary because there are other genders and the program does capture them. If you see, TB program is the only program which also captures data on the third gender. And it's officially captured on the Nikshay website. Tell me any other program in India which captures that data. So that's heightened level of sensitivity and responsiveness towards the women and the other gender is there under the National TB Elimination Program of the country. The other factors remain there. I mean, there are Blessy referred to stigma and discrimination. There is also self-perceived stigma. Women actually tend to delay care seeking. I mean, there's another dimension to it that you have to develop up your communication in such a way that which is a call for action, and they seek early care and treatment. But the self-perceived stigma is also a huge component of this stigma or discrimination which others give to you. You also give stigma to yourself. So there are many dimensions on care. Women also sometimes tend to delay care because they are looking after household, they are looking after children, and they, in a way, even without stigma, they tend to ignore their own health care. So these are all social factors which play out specifically and will vary from context to context. It is different in metros, it will different in rural areas, it will different in one state, other state. So these are very nuanced social factors. But having said that, there are general themes which run across the issues generally the women face. So these all factors, and that's what Blessy and most other panelists are referred to it, is that patient-centered care. So patient-centered care is another way of saying what we say in medical jargon is patient-tailored treatment, or the regimens you tailor as per the what resistance profile the patient is having. Similarly, you can also tailor your care toward the specific social context in which that woman or that gender is experiencing in the society. So that's what they are referring to as patient-centered care. It's a huge area. You need a lot of empathy to be actually feeling that how the patients or women in that space they are feeling about it, and needs a huge hand-holding and work by advocates like all those who are present here and social scientists here. I hope it's a difficult question to answer.
I think Dr. Sachdeva, that was great. And I can see Blessy writing in caps. So I think that's our takeaway. But we've run out of time, and I'm sorry to everybody who's left questions. I'll make sure that we send those out. But, you know, Dr. Singh started us off by talking about how policymakers can bring in a change. And sir, thank you once again for being here with us, to really also taking it down to the community. And, you know, we'll have to close out, and I'm going to request my colleague, Mr. Joseph, to come in and deliver a vote of thanks and a heartfelt thank you to everyone who's attended and been with us. Joseph, over to you.
Yeah, good evening to all. It's my privilege to offer a vote of thanks on this occasion. The entire participants and personalities contributed in this webinar, I strongly feel that I would like to call them as a fraternity of gender-transformative TB response in India for sustainable tomorrow. That kind of an impact which was made. Moving to my responsibility, I should mention the deep meaning of her appreciation for Ms. Sangeeta Patel, Director, Health Office, USaid, her explanation in the opening address about the context of the COVID pandemic, TB and communities in particular. She emphasized the USAID's commitment to adopt a gender lens for all their investments, and she explained that in India, USAID and its local partners strive to improve the lives of citizens to participate fully in and benefit from the development of their societies. On behalf of KHPT, thanks a lot, Ms. Sangeeta, for the wonderful insight as an opening of this important webinar in the context of International Women's Day. In addition, we express our heartfelt gratitude to Dr. Dalbir Singh, President, Global Coalition Against TB, for highlighting the micro-level societal issues and the need of a policy decision in his speech. We reiterate our sincere thanks to you, Dr. Dalbir Singh.
Right.
I would like to express our sincere thanks to Dr. Rajendra Joshi, Deputy Director General, National Tuberculosis Elimination Program, Ministry of Health and Family Welfare, for giving excellent coverage to his speech idea. Appreciable that he has given importance to the pathways that India continues to work towards the goal of TB Mukt Bharat. It is essential to account for the voices of the most vulnerable and marginalized communities, which is going to impact. Thank you, Dr. Rajendra Joshi. We are really glad for the participation and deliberation of Dr. Yemi, Senior TB Technical Advisor, USAID, Washington. She explained that evidence finds that men have a higher chance of contracting TB. However, real life experiences show that women and transgender communities face a disproportionate social response. If we are to ensure holistic response where the disease is eliminated along with its negative social connotations, it is essential to work with all actors involved in the fight against TB. Thank you very much, Ms. Amy, for joining this webinar and enriching it. It is Dr. Luchika, Executive Director for the Stop TB Partnership, Geneva, who had given a perspective on marginalized people who are in distress due to their gender identity, including women and transgender people, have to go through daily suffering and discrimination. Radical changes in this situation is inevitable. We are really happy for the commitment expressed by Dr. Luchika towards marginalized communities, especially the suppressed and stigmatized genders. We thank you, Dr. Luchika, for the precious thoughts shared with us. We are all very grateful to Ms. Blasina Kumar, CEO Global Coalitions of TB Advocates, for analyzing the context of gender disparities in that society and making the point affected communities are not just passive recipients of care, but valuable partners to end TB. TB prevention, diagnosis, and treatment should form core components of health interventions for women and transgender people. This also needs to be addressed for the LGBTQ+ community, the sex workers, women using drugs, and women with disabilities who have to go through additional stigma and discrimination in seeking healthcare. This has really hit us the most. Thank you, Blasina, for making the meaningful remarks. Thank you very much. We would like to thank Dr. K. Sachideva, Regional Director, the Union Southeast Asia at International Union Against TB Lung Disease, for the insights on the epidemiological point of view on the gender diagnostics and gender response in TB. Thank you, Dr. Sachideva. You are always with us as a mentor every time. We are really thankful to you, and also thank you very much for making the remarks and enriching the webinar. Thanks a lot. It is Dr. Rehana Begum, Project Director, Breaking the Barriers, KHPT, explained about the vital role of human-centered approach for effective TB response. KHPT has been working with community structures to make the fight against TB inclusive, patient-centered, and people-centered. I express the great appreciation and thanks to you, Dr. Rehana, in this occasion. Ultimately, Actually, the major investor behind this webinar is Dr. Sukriti Chauhan,
God, Joe.
the advocacy lead of BTP KHPT. She deserves a hats of wish for pragmatizing this.
Thank you.
Appreciate you, Dr. Sukriti, and thanks a lot.
Thank you, Joe. Thank you for that. And like, I want to just say that, like Blessina said before we close out, thank you for being patient. I know we are 10 minutes over. It's not easy, but it's not an option. Please take that away as you build your programs, you implement them, you work with communities, and a heartfelt gratitude to everybody who's joined. And my apologies that we've run out of time, but I will come back to you with answers. Thank you so much and have a great evening, everyone. Bye.